So next we'll talk about the direct factor 10 inhibitors. So we have rivaroxaban and apixaban. So these are the two main ones. So rivaroxaban is an oral factor 10A inhibitor. And similarly, apixaban is also an oral factor 10A inhibitor, obviously. So the good thing about these drugs is they do not require monitoring. So you don't have to take their blood to monitor how is the clotting going on every few hours. So that's very convenient for both staff and patients. And rivaroxaban is currently used for DVT prophylaxis in patients going for a knee or hip replacement, and also for stroke prevention in patients with non-valvular atrial fibrillation. So the theme is recurrent. It's always about DVT, stroke, okay, atrial fibrillation. Okay, it's always the same themes. Okay, and which is also similar here. So it's stroke prevention in patients with non-valvular atrial fibrillation. So again, looking at the ABGT and BT pathway, so you see that this is factor 12 activated, factor 11, 11A, 9, 9A, 9A activates factor 10 to 10A, and then prothrombin to thrombin. So we have factor 10A and factor 5A here, and thrombin converts fibrinogen, okay, factor fibrinogen to fibrin, and then here the cross-linking of the fibrin clots. So what rivaroxaban, apixaban, and edoxaban, what they do is they block here. Okay, so this is where they inhibit, they stop the action here. So they stop factor 10A from converting prothrombin to thrombin. So in the end, the downstream of it is that you don't get fibrin, you don't get the clots, okay, you don't get the clotting. So that's how you get the anti-clotting drugs of the direct factor 10 inhibitors, rivaroxaban, apixaban, and edoxaban. So there are many studies done with regards to this newer anti-clotting drugs, relatively newer. So for example, we have this apixaban being used to treat patients with acute coronary syndrome or patients who have PCI in atrial fibrillation. So they're looking at and they compare the results and see better results in apixaban, because you see less major or clinically relevant non-major bleeding in the apixaban group compared to the vitamin K antagonist. So the next group are the direct thrombin inhibitors. So for the third group, we have the direct thrombin inhibitors. So these drugs are based on proteins made by the leech, the medicinal leech. Not sure what does that mean. I mean, is that how many types of leeches do we have? I'm not sure about that. Okay, So I've only seen one type, okay? And then, so the common ones are lepidolin, desirudin, bivalirudin, okay? And also we have argatroban. So these drugs are given parenterally. So protein analogs of lepidolin bind to the thrombin active site and the thrombin substrates. Whereas, so we have lepidolin and the desirudin and bivalirudin. So these all bind to the thrombin active site and thrombin substrate. So they bind to both to the thrombin active site and also to the thrombin substrates. Whereas argatroban only binds to the thrombin active site. So they will inhibit both soluble thrombin and the thrombin which has been enmeshed within developing clots. Okay, those that had been trapped, those had been entangled within the developing clots will be inhibited by these drugs. So direct thrombin inhibitors. So they are used as alternatives to heparin, and similar to heparin, we have to monitor the APTT, the longer pathway. So I like to remember it as the longer pathway, or you can also, it's also known as the intrinsic pathway, of course. And the adverse effects potentially from this drug is you can see bleeding, which is quite straightforward, and then we might see anaphylactic reactions. Something about dabigatran. So it is a prodrug that is rapidly changed to dabigatran. Okay, so dabigatran ataxylate is a prodrug which will be converted to dabigatran, and that will block the active site of thrombin reversibly. And with the other drugs like the lepidolin, desirudin, bivalirudin, okay, so these drugs, they do not require monitoring of the coagulation. So you don't have to do the APTT regularly because the response is quite predictable. So we know we can predict what's going on. So which is better in that sense compared to the conventional drugs. They are the older drugs. So it's used for stroke prevention in atrial fibrillation. So the APTT, or we call it the PTT pathway, so 12, 11, factor 12, 11, 9, 8, 10, and then factor 10, factor 5 there, prothrombin to thrombin, fibrinogen to fibrin. So prothrombin to thrombin. So this is where the bigger trend comes in. This is where it acts. So it acts by blocking thrombin, okay, the activated factor 2. So when you stop it here, again, in the end, you don't get fibrin, so you don't get the cross-linked fibrin clots, okay? So just showing you one study comparing dabigatran and aspirin in in stroke. So you can see that they gave this 110 or 150 milligrams twice a day dabigatran compared to once a day aspirin 100 milligrams, so which is just quite a standard low dose therapy. So you can see that you have a lower rate of recurrent stroke with dabigatran. Okay, I don't remember whether this is statistically significant or not. Okay, but you can see that this study seems to show a bit of change there, but maybe it's not significant. Okay, and then here for major bleeding, again dabigatran versus aspirin. So you can see that it's not that different. Okay, so so it's mentioned here dabigatran was not superior to aspirin in preventing recurrent stroke. So you can see that. So it's not statistically significant. There's some minor change there. Okay, but it's not significant. So you can say that in this sense that dabigatran is quite comparable to aspirin. Okay, so it's not superior or inferior to aspirin when it comes to treating embolic stroke of undetermined source. So you're not sure what the main source of the emboli. So sometimes these drugs, when they're lumped together, they are known as the NOACs, okay, the non-vitamin K oral anticoagulants, okay, non-vitamin K oral anticoagulants. So NOACs, dabigatran, rivaroxaban, apixaban, and edoxaban. So a few years ago, they were trying to produce this idarucizumab, okay, which is supposed to be to counter the action of dabigatran. So this is the drug that you're supposed to give if you have bleeding due to dabigatran. And then we have the andexanate alpha, okay, to overcome um, what happened, bleeding that happened due to factor 10A inhibitors. So in the next video, we will talk about warfarin. Okay, see you in the next video.